So welcome back. Today we'll be talking about a disease called Sjögren's, and it is a fairly newer disease, meaning that it really wasn't first detected until the late 1800s. And in 1933, an eye doctor from Sweden, Dr. Henrik Sjögren, first described the disease in a few of his patients. And he noticed these women with very intense dry eyes also seemed to have an arthritis. But when he first brought it to the attention of the medical community, they said, no, it's not. And so he waited about 20 years. He gathered up some more patients. He went back and he presented the disease again. And this time around, it was accepted. And actually, the disease is now named after him. Now, what is Sjögren's? Sjögren's is when the immune system is overactive the wrong way and it starts to attack the exocrine glands in the body. Now, the exocrine glands in the body are things that make things that other parts of the body need, but what they do is they make it and they send it through a duct or a pipe to that other body part. So for example, the lacrimal glands make tears for the eyes, the salivary glands make water for the mouth, the sweat glands make water for the outside of the body to kind of cool it down. We have glands in the digestive system that make things to help us break down food. But in Sjögren's, what happens is the immune system preferentially attacks the lacrimal glands and the salivary glands. So these patients will get a lot of dry eyes and dry mouth. Now, there are two different types of Sjögren's, and this becomes a little bit more important later. The first type is called primary, which means that the patient has just the Sjögren's disease and nothing else. And then there's a secondary type, which means that the patient already has a rheumatoid arthritis or a lupus or something else, and then they have Sjögren's on top of it. As far as the symptoms of Sjögren's, the first and foremost is the dry eyes and dry mouth, and these are called the sicca symptoms. Sicca comes from Latin meaning dry. These patients also get a very specific type of arthritis. It looks like rheumatoid arthritis, meaning the small joints, both sides of the body, etc., but it's non-erosive, which means it doesn't really eat away at the joints in particular. These patients can also get attacking of the muscles, they can get attacking of the nerves, and they can also get attacking of the skin. They can also have attacking of other things on the inside, like the larger organs, such as the lungs and the kidneys, the pancreas, the brain, etc. So if you think about it, Sjögren's can kind of do everything its sister disease lupus does, but it usually doesn't. So when I explain it to patients, I usually say this is like a diet version of an autoimmune disease. Now, who gets Sjögren's? Well, it is a common autoimmune rheumatological disease, but it's still very rare because our diseases are rare to begin with. So if you take the example of how many people do I need in a room, I need about 30,000 people or maybe a little bit more for even one person to get that. It is more common in women. 90% of patients with Sjögren's are female. It usually starts around the ages of 40s or late 30s, etc. It is genetics. It does run in families. And those patients who have rheumatoid arthritis or lupus or another disease, they tend to have they're more at risk for Sjögren's. They tend to get this disease a little bit more than people that don't have that as an underlying disease. Now, how is Sjögren's diagnosed? Well, as you can gather, dry eyes and dry mouth is a very common thing. So in this disease, you have to pay a little bit more attention to what the patient is saying. So in this case, as a rheumatologist, you want to hear that patients have severe dry eyes to the point where they can't wear their contacts. They have trouble seeing at times. They always have this gritty feeling in their eyes. They have severe dry mouth to the point where they're seeing the dentist all the time. They're getting their teeth pulled. They're having a lot of cavities, etc. And then when they go to the eye doctor can actually do some specific tests, and they can see that the surface of the eye isn't getting enough tears in it, so there's actually some damage there. And they can also do some tests to see how much tears the patient is actually making, and that tear production is lessened in these patients. There are some blood tests. They can be a little bit more specific or a little bit more unique to these patients, but they're not all diagnosing, like they can't make the definitive diagnosis, but they can help with the diagnosis. And some patients actually will need a lip gland biopsy. And so this is a biopsy of one of the lip glands or the exocrine glands that are just inside our lip. And when those patients, you can take a piece of that and you can look at it underneath the microscope and you'll see some abnormal autoimmune cell activity in these patients. As far as how these patients are treated, well, it really depends A, on the type that they have, and B, what symptoms they are having. But first and foremost, it basically involves a lot of different doctors. So you try to treat each symptom in these patients. So for the dry eyes, they will go to the eye doctor. They may get special eye drops. They may get special medications. They may even have procedures done to try to keep the tears in their eyes a little bit longer. Seeing the dentist regularly and taking medications or taking supplements that will help increase the saliva production in the mouth, brushing the teeth constantly, etc. And then also seeing the rheumatologist if there's joint stuff or if there are other things that are being attacked on the inside, like the lungs and the kidneys, so that we can coordinate with the kidney doctors and the lung doctors for some autoimmune medication that'll help calm that down. And then for the neuropathy, seeing the neurologist, and then for the fatigue, seeing the primary care physician. Now, how do patients with Sjögren's do long term? What is their prognosis? Actually, it's pretty good, but again, this is where that subtype makes a difference. So those patients who have the primary Sjögren's, meaning that they have Sjögren's and nothing else, they are actually at increased risk for a type of blood cancer called lymphoma. So they may have to be monitored a little bit differently. It's not as common in them, but still, if you take like 100 of those primary Sjögren's patients, about 10 of them can have or develop that lymphoma. In the secondary Sjögren's, it really depends on the underlying disease. So how well is their rheumatoid controlled? How well is their lupus controlled? So how was the underlying disease controlled? Because then that will determine how well their Sjögren's is controlled. And then finally, in pregnant patients. So when patients are pregnant and they have Sjögren's, there is a little bit different blood work that has to be checked in these patients. Their pregnancy has to be optimized, meaning that their disease has to be controlled. Maybe certain medications have to be switched, and maybe the baby will have to be monitored a little bit differently throughout the pregnancy. And this is actually not unique to just Sjögren's. It's actually for all autoimmune rheumatological diseases. Those three things, like optimizing the pregnancy, checking the right labs, and changing of the medications is important. So as you can see, Sjögren's really requires a lot of different types of doctors to get involved in the patient care, which is why it's really important to know what kind of person has this disease to better give them the treatment options that will help them the most. As Dr. Ozer would say, the good physician treats the disease. The great physician treats the patient who has the disease. Until next time.